In this video, we're going to talk about the different surgical options for transfeminine bottom surgery. So for folks assigned male at birth, what are the different options? And I'm going to go through 6 different options because when it comes to gender affirmation, of course, one size doesn't fit all. And we need as many options as possible, really, and we need to educate folks about all the different options so that they can make the right choice for themselves. So I'm going to start off with option number 1, which of course is surgery is not obviously necessary for everybody, and it doesn't make you obviously any way less trans if you decide not to do bottom surgery. So no surgery is a perfectly legitimate option, option number 1. Option number 2 is orchiectomy, or just removing the testicles. And we now see in my practice, I'll see more patients opting to do that separately. Traditionally, we could combine it all with vaginoplasty, which we still oftentimes do, but some patients, for various different personal reasons, may choose to do it a little bit earlier. For example, if they're having problems with their medications, or they're not at a place in their life where they're ready for full vaginoplasty, but do want to go ahead and do the orchiectomy, and it's perfectly acceptable to do it by itself. It's a relatively quick and easy procedure compared to full bottom surgery, and can be done as an outpatient with not much downtime. So that's orchiectomy. Orchiectomy with scrotoplasty is option number 2, and that's where we remove the testicles, but at the same time as removing the testicles, we're going to get rid of the extra skin or scrotal skin down there as well. This traditionally is not for patients who may want to do full bottom surgery in the future, because we want to leave behind as many spare parts as possible for if and when we're creating the new feminized anatomy. So typically, even with new advances such as the peritoneal technique, I do recommend, if full bottom surgery is in your future, leave the skin alone. Otherwise, we can remove that skin. It helps with tucking. Some patients like the appearance better, and it leaves behind a scar depending on how much tissue that's there. It can be a few inches long. We usually use dissolvable stitches, but again, an outpatient procedure, not much downtime with that one. So that would be option number 3. Option number 4 is doing a zero depth bottom surgery, or labioplasty, or there's lots of different names for this type of procedure. And again, it's really important that folks have awareness that this is an option. And in this procedure, we're doing everything, all the steps of bottom surgery, except we're not creating the vaginal canal. So we're feminizing everything on the outside. From the outside, you can't really tell the difference, you know, because we will make a dimple, we call it, or the start of the vaginal canal, but we're not making the canal itself. And there's various reasons folks choose this. It greatly decreases the chances of complications from vaginoplasty. It gets rid of the need to dilate after vaginoplasty, and it really just depends on the individual patient's needs. And I always say, if you don't really want or need or are going to use a vagina, this may be a really good option for you. In certain situations, for various medical conditions, that is more so going to be the way to go. And the most typical one is somebody who's had their prostate removed already, usually for prostate cancer or prostate radiation. And the reason for that is, when we do create the vaginal canal, there's very limited real estate down there, meaning there's not much space between the rectum, where you poop from, down below, and where you pee from, or the prostate above. And when you've had the prostate removed already, the tissue tends to be scarred and much more sticky, and it's much more difficult to create that canal, making it a much more risky surgery. So most surgeons recommend in that situation that a zero depth procedure, or skipping the canal part of the procedure, is going to be the better option. The next option is vaginoplasty. And so basically there's 2 ways in my practice we make the new vaginal canal, and I'll summarize those briefly. So first of all, we have penile inversion vaginoplasty, and this is still the most commonly done in the United States. And this just means that we're using all the external anatomy below to line and create that new vagina. And typically that vagina is going to be partially lined with some of the penile skin, and usually the deeper portion, if needed, will be lined with the scrotal skin. And again, in my practice, this is still very commonly required, or asked for, and it is a procedure that does well. It's time tested. Now, the other types of vaginoplasty really involve just lining the vagina with something different, okay? And by far the most common something different we see being used is the peritoneum. What is the peritoneum? It's not something you hear mentioned very often. It's basically just like the way we have a skin on the outside of the belly, there is a skin or a film on the inside of the belly, and we can lift that up and use it to help line the deeper parts of the vagina, or bring as much of it down as possible to the entrance of the vagina, like we do in our practice. So myself and the urologist I work with, he will go in from above with a robot and bring down a flap of this peritoneum while I work from the bottom, and then we meet, and usually he can get it very low in the pelvis, whereby most of the new vagina is peritoneum, or it's a pouch. And so those are the 6 different ways, broadly speaking, of how to do bottom surgery for folks assigned male at birth. And like I said, there are other ways to line that new vaginal canal, but in general, in the United States, those are the most commonly used ones. Sometimes you hear about colovaginoplasty, where you're using the colon or intestine. This is much more rarely used in the United States, unless maybe as a secondary procedure or a backup procedure for folks who have had stenosis or narrowing from one of the other ways to line the new vagina. So in general, that's how it's done. I hope you found this useful. If you want more information on this, check out our website. I have written it in the comments below.